Remember the Hydatid. What's the Hydatid cyst? So as we know, this is the Hydatid cyst in the human being. It's a larval stage of infestation with Echinococcus granulosus, which is a top, which is a dog tapeworm, which is common in the tropics and less common in the other countries. But as I said, still it is present in Iraq. They have a definite host and intermediate host, and consider the human being as an intermediate host, but the definitive host is the dog. And usually they are characterized by the Hydatid cyst by 3 layers, which is the outer layer, which is the adventitia, which is the tissue response to this tapeworm infestation, and the inner layers, which is the fold, the native membrane, and the inner cyst, this is the germinal layers, or what contain this infected layer and contain the sand and the daughter cyst with polycyclic agents, which is the most important. And they are classified by the WHO in 2013 into the 3 groups, group 1, 2, and 3. According to the size, they are either the active group, which is more than 2 centimeters and it is active, and the intermediate or transitional group, which consists of the cyst, started to degenerate and entering the transitional stage because of the host resistance. Please interrupt for this. And the group 3 is the inactive group, which is the degenerative or partially or totally calcified, unlikely to be contained the viable root cell. The clinical presentation of the Hydatid cyst, as we know, the Hydatid cyst either have a mass effect or another effect due to its composition. So the mass effect will be the patient. Most of the patients usually presented asymptomatic, and they discovered during the seeking for the other and doing an ultrasound for the other things, political concerns, then would be found Hydatid cyst in the liver. And the other presentation due to the mass effect, which could be presented with pain, usually adult pain in the upper abdomen, and most of the time due to the anaphylaxis presented due to the rupture of the Hydatid cyst. Usually when it's ruptured into the peritoneal cavity, it could be a spread of the Hydatid cyst and also the anaphylaxis. In addition to that, there is mainly what is called intrabiliary rupture. It's not the intraperitoneal. What is the intrabiliary rupture of the Hydatid cyst due to the inside the biliary tree within the liver, and they transmitted to the main right and left hepatic and then to the common bile duct, causing the obstructive jaundice. And usually there is a statement for our teacher, Ahmed Al-Sagban, the Dr. وقت ذكر my colleague إنه when there is a young patient, healthy, wealthy young patient in Iraq presented with sudden onset of obstructive jaundice, so you think for intrabiliary rupture of Hydatid cyst. And still, this statement is present and it is documented. Diagnosis of this started by the history examination and then same for investigation, usually by the ultrasound and a CT scan, in addition to the serological test with ELISA test and the eosinophilia. But the diagnostic test for this is the ultrasound and CT scan. This is the features of the Hydatid in the ultrasound, how it's appeared, and this is the CT scan, how it's appeared, which is the multiple cyst and contain a daughter cyst with, this is the laminated membrane, and also the liver. And we know usually the most common effective organ by the Hydatid cyst is the liver, and then the second is the spleen. The treatment, we started with treatment of Hydatid cyst, started with a medical treatment with albendazole in such a case, and mostly by the surgery. And the surgery, depending on the started from conventional open surgery into the repair, and then with a minimal invasive surgery which contains the laparoscopic surgery and the repair. What we mean by the repair, it is a puncture, aspiration, injection, and re-aspiration, and it's different from the laparoscopic. This is a percutaneous. This is a percutaneous, that is a puncture, aspiration, and then injection of the scolecidal, and then we re-aspirate. And we don't do any opening or any surgical interference. But this have a special precaution, and depending on the number of the cyst, and depending on the anatomical position, and we do the treatment of it. Really, the treatment of laparoscopic or any conventional treatment of the cyst usually started with, first of all, prevention of the spelling of the Hydatid cyst, number one, so that's protection, and then dealing with aspiration and with the withdrawal of the content to outside without contamination, and the third, dealing with the cavity, keeping the cavity that presented or remain in the liver. So, started with indication of treatment, medical therapy. We give it usually 4 days before the intervention. Start with albendazole or mebendazole, and I give the Zental, what's common in Iraq, if it's available, Zental tab, 400 milligram 1/2. Really, I give him before more than 4 days, 5 or sometimes even 1 week, and then continue after the surgery for at least 1 month. And then the inoperable cyst, also that has medical treatment medication for the multiple or multi-organic cyst within, and the recurrent Hydatid cyst, surgically unfit surgery, patient cyst in the lung, bone or brain, sometimes for the medical treatment. Laparoscopic management, as the literature, we know that it's a minimal invasive surgery, and laparoscopic it's very grateful for the dealing with this problem or with dilemma. So this consists of the removal of the endocyst, contained endocyst, along with a daughter cyst, and the most common procedure, the initial steps is aspirated, and usually I have movies here for the operation. Usually they started with this. What I do from the aspirate, from the starting by the positioning of the patient. We do usually, as you say, this picture, they do with more than 4 or 5 ports. What I do really by a 3 port, and I will show you the procedure. What I do, the position, starting by the position of the patient, that is what the patient, as it's in the liver, so we have a downward, the head down, and tilted to the right side. So any spillage of the cyst can come from the cyst during the aspiration, can remain in this area. And before that, we put those impregnated with 10% betadine, which is called a scolecidal, which is the safest one scolecidal agent that used. And in addition, so after aspiration, and we assure there is no biliary communication, we can inject a scolecidal for a while of the time, which is 10 minutes usually, and then usually I use the betadine, 10% for betadine. So this is by the injection, by the needle, through the trocar. This is the betadine. After a drop and emptying the cyst, I put the betadine and then refill again the cyst and remain it with the betadine fully. And that is then aspirated by the fluid, all the fluid, and we open, and this is the daughter cyst after extraction, or the laminated membrane, and this is the final 3 port, and this is the drain, put it in the cavity in addition. And I have a video, just excuse me. So let's start the video. for this operation. This sorry. Let's start with this video for this patient, which is a 45-year-old female presented with pain, and during investigation they found to have multiple hydatid cysts related to the segment, started from this segment 7, 8, and then along the diaphragm, which contacts the diaphragm, and the other one. Really, the CT and the ultrasound, they say the 3, but I found this 4, which is the most common finding, is more than 1. And then dealing with the, I will proceed. So, using this safety port for entrance, and then use the third, and now putting this gauze-implemented betadine to isolate the field. In addition, as I said, I told the patient in position that to prevent the spillage of the fluid, and then dealing with this. So, as you know, this spillage will occur in this this betadine, and then we'll aspirate that. And then after that, this I put a betadine for the outside to be contact with any spillage. And then we open this, the cyst. This is the ectocyst and the epithelium, and then this white color is the endocyst, and then we try to remove it by using, we have not a special part, but what I do, the gloves, I cut, and then suturing, I put inside, like that, inside the abdomen, and then to be worked as a connecting part. So I draw this. Starting to withdraw the laminated membrane on this, and then put inside. And look, we hear this to the cavity. Another advantage of laparoscopic surgery, as we can enter inside the cavity and look for the others. And the cavity is the most important. We can do this is what is a more septated cyst, and the other cyst inside is hidden inside. Also, we can withdraw it. The other cyst dealing with that, the same procedure is, this is in contact with the diaphragm and nearby the heart. This is the midline and the diaphragm with the heart above. The other is a continuation of the, really I have to facilitate this video as it's long, but it is unedited. Each part is about 17 minutes, and then it is a 4 videos. What I say here, what to deal with, this is the inside, we are inside the cavity, and we can look for any other daughter cyst present, and we can withdraw it outside also. And after withdrawal, we left a betadine and a spermicidal for a while dealing with the others. So it would be contact and time enough for killing any daughter cyst or of course other cyst. So these are the same. Here, what about the end? Now, how we deal with the cavity remain? This is the problem, residual cavity. This is the most important. Usually I say to the patient, and this is the most important in reactivation, that I will put a drain. And a drain, it is either it's removed in 1 week or 1 month or 7 months, or may need another endoscopy by ARCB. So you have to do, and you have to inform the patient about that. Because if there's a biliary communication, so there's a big problem. Especially the side, this side, especially as it's about near the diaphragm, so the negative pressure, or the movement of the diaphragm will cause a negative pressure and withdrawal of the bile to the least resistance. And we have this continuation. What I noticed really, that most of the Hydatid cyst, when we withdraw without a clear, it will be a clear, and there is no clear communication. But after we putting a drain, after our 2 days or 3 days, there will be a bile leak through the drain, so that I prevent myself from the blame of the patient about what happened and what is the drain, what's this. I tell to the patient everything, and this drain could be removal, depend time, they will depend on what is the discharging from it and how it stops and when it stops. Okay, and it's may need. So this is by the cauterization, we remove the other side. For the cavity, we have, as you know, we have many options. One of them is putting a drain, or the other thing is omentoplasty, and the third, when we find a connection, a biliary connection, if we can suture it, so we can do it. So really, I have videos for another patient here. I will so dealing different types dealing with the cavity of this. One of them is the intracavitary suturing of the bile connection. I did it, I think, on 2016 for many years, and then it will be appear here. This is the same. Okay, just. Now, after we finish the withdrawal of the uterus cyst by the gloves, I put another one and stopping with the cavity with this betadine impregnated gauze. Here, this patient, as you saw, this have an cyst in the most of the liver of the border of the right block of the liver, and it is connected. It will become nearby. So I connect all them by cutting by a ligature. All these continue to become one cavity, and then put a long drain, tube drain along this side. This is one of the. Here, most of the wash, and after this is cutting, and this is the main, could become one cavity. I put the drain inside, and then after that we remove all the. This is the drain, what I say to put. Okay. Just a minute. Now, the other procedure for dealing with the cavity is putting the omentum, which is omentoplasty. And this is, and I put with suture to fix them inside this cavity and to be sure it will be. So I suture it with the periphery of the liver. and cyst. This is the oldest one. That is here inside this. This is another patient. I found, or I noticed the connection below, so I suture it inside the cavity. I make a figure of it to closure the biliary connection. And it's doing well. The patient removed the drain. This is inside the cavity, and this side, this was biliary connection, primary connection. So I put a figure of it to close the communication, and then put the drain and removed after a while. Anyhow, for me, I will never remove the drain inside from the cavity unless 1 month ago. Pass through the operation, because make a tract contrast. If you need a biliary connection after 1 month through the drain, I'll send the patient for ARC, endoscopic laparoscopic, to abolish the distal sphincter of OD pressure to make, and then negative pressure of the movement done by the movement of the diaphragm. They will be abolished, and again putting a stent, giving the time for the liver to grow and close this defect. What is here, the last patient? This patient's surgery done before I came here. This have large liver Hydatid cyst, and also the same, it has a huge ovarian cyst done by the same time, by the same. So this is the after removal of this Hydatid cyst. Thank you. This is the Hydatid cyst.
Thank you.